Hey everyone, good afternoon. You're all having a good day so far. Last time you'll be seeing me for the week is maybe. Is that an Allison? It's funny you guys like this before it even starts. Like, how do you know you're gonna like it? It could be, it might be a bad lecture. You're all having a wonderful afternoon. No, I have a button that I'm pressing on the mic to make sure that I don't blow your ears out when I cough or sneeze. But occasionally I might let one slip through it. Yeah, that would be pretty sweet. You know, I'm getting tired of you blend flex people thinking and just be in the same room together. What is this, pre-COVID times or something? You just have I mean, I guess you had neuro before me probably. Professor Kaplan was doing the blend flex. Hopefully that went well. I was curious to see how that's gonna work on the technology side. That's great. I imagine too, like just being able to like talk in person probably helps out with the it probably causes people to go over a little bit just because you can actually like converse with one another. It'd be pretty. I'm gonna see if I can do it for a review or two. I gotta see if I can work that out with the schedule. So I'll let you guys know on that because those are usually Zoom anyway. So that might work out. Depends if I can do it like with my own hardware. If I can use like my laptop and stuff, like so I can record it and upload it like I normally do for people. Glad you guys would appreciate that. What's left? To play D&D after though. I don't know about that. I'd hate to embarrass you guys with how awesome I am at it. I'm just kidding. I've never actually played a tabletop game before. I've really relied on computers to do my dice rolls for me. Although I'm real excited, the Mass Effect remastering is going to come out in May, so I might have to disappear for a few days and get played through all those again. All right, well, it's 2:30, so let's go ahead and start it here. Thank you everyone for joining me. Hopefully you're having a nice day so far this afternoon. Here, Mass Effect, you just think of the brain now. Think of Shepard. But anyway, so we were talking about bipolar disorder yesterday, I guess, and we were discussing how we can use our mood stabilizers for this patient. So those really help out with dealing with the manic phases of things. Keep in mind, for the more depressive phases, that's where your antidepressants are going to come into play. So you can start to see how these medications are going to start to kind of add up with one another, and you can see some of these side effects start to sort of, be synergistic amongst the different classes we're dealing with here. But One thing we'll do when we have patients who are particularly challenging to manage from the manic side of things, we can introduce our antipsychotics. And so I'm going to get much more into this in just a few moments here, but just to briefly mention them, the main ways these drugs are going to work, we'll talk about them in terms of their effects for schizophrenia, but here how we're utilizing them is by blocking dopamine 2 receptors, if you D2 or DA2, it just depends. I'll break them up in their first and second generations in terms of their actions, and there's going to be some differences between them. But we'll see for like acute manic symptoms, and some of you may have worked in an ER, I've seen this before, like if you give someone Haldol or Geodon or something like that to really sort of knock down a very agitated, aggressive patient, like this is some of the drugs we might use potentially. So if they're like actively hallucinating and thinking they're going to harm themselves or someone else, this is the type of situation we'll do that in. Sometimes we'll use them in conjunction just for like routine maintenance therapy, but that's not as common. Usually the mood stabilizers are mainly used for that. We're going to see that in terms of long-term therapy, there's going to be some issues with this. We'll talk about the metabolic effects here in just a little bit. So I'm not going to, we'll get into deeper detail on that in just a few moments, but these are options. You have acutely manic patient who's potentially dangerous. This is the set of drugs you're going to use here. But we'll talk about those in just a moment or two. So anyway, what are some alternative agents we can utilize potentially for these patients as well? Benzodiazepines are going to be another option in terms of managing the acute manic episodes. So benzodiazepines, like we've talked about before, like Xanax and alprazolam, midazolam, all those drugs, they work as anxiolytics. And so it makes sense how they can be used to help kind of fill someone out a little bit if they're having like a really kind of an acute manic phase there. So in that ER setting I was talking about, where you might give someone antipsychotic like Haldol or something, you could do a benzo in place of that. And sometimes they may even get both depending on how severe the case may be for that case. You may use these chronically though for patients who can't take mood stabilizers, but this is probably not going to be the best bet because there's a lot of tolerances seen with it. It can interact with a lot of illicit substances. So we'll talk about more of those in detail in just a little bit too. Some people even feel like calcium channel blockers might be able to be helpful for this. So for instance, like verapamil might have some mood stabilizing effects. And then even like nimodipine, which is a dihydropyridine, has pretty good effects. And we actually use it a lot for patients who are post-stroke because it does help prevent sort of like a vasospastic ischemic events. And so, but it penetrates the brain pretty easily. That's why we like nimodipine from that standpoint. But, it's thought to may also have some mood stabilizing effects as well. So generally speaking, you'll probably see patients start off on something like lithium or valproic acid. You may add on like a carbamazepine, but these could be alternatives if they were not really good candidates for those kind of mainline ones. So generally speaking, you want to start off with a mood stabilizer, just like I said. So generally, valproic acid, lithium, carbamazepine. You use a second generation antipsychotic. It's a SGA right there, not Student Government Association. I don't think they are too good at stabilizing moods, as if history serves as any guide there. But just kidding. SGAs are always pretty fun. But so we'll get into those in a few minutes here. You can consider if they have like, acute anxiety issues or like agitation, insomnia, benzos can be like a nice add-on in those sort of situations there. Oxcarbazepine you probably use as more of an alternative. We just don't have as much evidence for its use necessarily. And then if we start to get to a case where we're having like really severe manic episodes, especially if it's like more recurrent, that's when you may want to consider using multiple meds here, like valproic acid plus lithium, for example. But be careful with the drug interactions. Make sure you're looking this stuff up before initiating something like that. So as an example, you could use lithium plus valproic acid or a second generation antipsychotic, anything like that would be perfectly reasonable, or you could use two of the anticonvulsants. You don't want to use carbamazepine plus oxcarbazepine because they're kind of doing the same thing, so I wouldn't combine those two, but those could be perfectly reasonable to use two anticonvulsants there. So that's mainly it for the bipolar section. Next, I want to talk about our medications for antipsychotics. So this is where we now get to talk about the meds I was talking about, first and second generation antipsychotics. So this is where we're mentioning it here. So why do people have schizophrenia? We don't really know. As with most of this mental health disorder stuff, we don't have full ideas on all of this, but certainly there is a genetic component to this. Some of it may be due to Hypoxia at birth causing issues with glutamate causing excitotoxicity. Who really knows? But what we're going to find here is that ultimately they're having an issue with dopamine receptor defects. So just like we saw with someone with Parkinson's having issues with movement due to lack of dopamine, we're going to find for these patients here that having dysregulation in dopamine in various parts of the brain is going to cause some issues. So some places are going to have hyperactivity, like you can see here in the caudate nucleus. Some places will have hypoactivity, like in the frontal cortex. And this is going to sort of lead to a lot of the symptoms that we're going to look at. We're going to talk about positive symptoms, negative symptoms, and the cognitive symptoms of schizophrenia. And so that's going to be more clear when we talk about the different areas and where things are maybe overperforming and underperforming, as the case may be. So, and again, you'll see with this dopamine overactivity in the mesocaudate, this is responsible for a lot of the positive symptoms. So when you think about like the typical schizophrenic patient, you think about someone who's hearing voices and they have these delusions of grandeur. Those are those positive symptoms that we're talking about there. And those are really the dangerous ones, as you're going to see with dealing with like an acutely psychotic patient there. But overall, it's pretty complex from a neurotransmitter standpoint. Glutamate probably has some role to play here, but we're mainly going to focus on dopamine and a little bit of serotonin activity here. You'll see that there's a complex interplay between different neurons and how they can have inhibitory and excitatory effects, as we'll see here. With serotonin, you're going to see that overactivity in the frontal cortex actually inhibits dopamine release, which we saw here, there's a hypoactivity. This sounds like a lot of gobbledygook, but it should make more sense in a few moments when I kind of illustrate the points here. So this is a pretty complex picture. Basically, it's just showing you different dopaminergic neuron projections here in the brain, whether you're in the nucleus accumbens, whether you're in the frontal cortex. And you're going to see that there are several different factors at play here in terms of releasing neurotransmitters that cause it's stimulatory effects to release dopamine, or they may have inhibitory effects. So for instance, something like GABA's an inhibitory neurotransmitter. So if you activate GABA, it's going to be decreasing dopamine release from neurons like this, right? Because it's inhibitory, so you should have less dopamine release. Whereas something like nicotinic acetylcholine receptors can actually have positive effects, can actually cause it to release more dopamine. But overall, what you're going to find is you're going to have too much dopamine activity being released here from the nucleus accumbens. This is going to be a lot of the positive symptoms you're going to see with schizophrenia. And in the frontal cortex, you're going to see there's too little dopamine. And this means you're going to have issues of negative and both cognitive symptoms. Okay, so we'll get into that in just a few moments. Notice here how too much serotonin activity would cause this to release less dopamine. So we know there's too little activity up here in the first place. And because this interneuron is not being triggered here, which is normally inhibitory, this just lets way too much dopamine activity happening here in the nucleus accumbens. Okay, so what I want you to take away from a pathophysiology standpoint is that kind of realize which symptoms are being caused by which effects. So when I say positive symptoms, which I'll elucidate on in a few moments, that's going to be related to too much dopamine activity. When we get into the negative and cognitive symptoms, that's related to little dopamine activity, and we'll talk about some ways we can manage that. Because what we're going to see is with the medications, while they may be really good for certain types of effects, they may actually worsen some of the other ones. And so there's a good movie out there. I guess that's a subjective opinion, but I think it won some Academy Awards, so maybe there's some objectivity to that. But have you ever seen the movie A Beautiful Mind with Russell Crowe? That illustrates, I think he's a mathematician that developed schizophrenia, and it's really interesting to see the effects of the medications as he goes on there. And if you watch that movie now, you may have some context when you hear medications like Thorazine and things like that. So yeah, very good movie. I recommend you check it out. I always like to bring up medical movies because sometimes they can be kind of ridiculous. Other times they can be pretty spot on. I think A Beautiful Mind is a pretty good representation of schizophrenia and how medications might, how it does affect that. And you'll see that in that movie there. Just as a brief aside, my most favorite terrible medical reference in a movie is in the there's a Wolverine Origins. There's an X-Men movie. A lady tried to fake her own death by utilizing a drug to slow down her heart rate to where she would appear dead. And that drug was hydrochlorothiazide. And I think I busted out laughing in the movie because I was like, you might pee your pants. I don't think it's going to make your heart rate go down. I was hoping for a beta blocker at least, but I guess their medical, whoever their medical, consultant was not too great. That's probably not the best movie to go watch anyway. That was something else. But yeah, people were very mad at me in the movie theater because I was laughing so hard. But anyway, getting back into the clinical presentation here. So like we were talking about with the positive symptoms here, we're going to see that patients, we kind of think about them as losing touch with the reality. You may accuse some of your professors for having some of these issues here, myself included, including like hallucinations. You have these delusions of grandeur, like I'm this like awesome professor and people want to hear me talk all the time. Obviously that's false, right? And you may even hear things like, ideas of influence, like, the voices told me to do this thing, something like that. Yeah, it's funny. So there are likely to be no movie questions on my exam. So I would not recommend that as a source for studying. Who is the second key grip on Wolverine origins? Probably not going to show up on the exam. That might be a more fun way to study though, but anyway, when we talk about things like the negative symptoms, though, you're going to see that these patients may also have like really kind of like flat, sort of inappropriate affects. You're going to see they may appear just to be kind of zoned out all the time, or it could be particularly labile, especially when they're having like an acute episode of psychosis where they can just get really, really aggressive, potentially, almost like a really bad manic episode. Oftentimes they have a really hard time with things like personal hygiene, maintaining jobs, relationships. And so this is going to be one of the big things we're focusing on with these patients and trying to get them back to some sense of normalcy there. They also have a really tough time too, because imagine if you were hearing voices that says, well, there's nothing wrong with you. You're fine. It's okay. Don't take your medications. Compliance becomes a big issue with this, and that means that there's going to be a lot of relapse and often, unfortunately, hospitalizations as a result of them not being compliant with their treatment. So that can be a pretty tough thing there. Grey's Anatomy, the surgeon said patient's becoming hypertensive. Quick, let's get his pressure up. Oh, that's funny. Sounds like someone would probably say thinking and speaking too quickly or something. Anyway, they also have a high rate of substance abuse with this too. You're going to see, especially with like ethanol, nicotine, any kind of illicit substance may be more prone to that than others, unfortunately. So as I was mentioning, there's positive, negative, and cognitive symptoms. So with positive symptoms, this is going to be things that are present that should not be there. So for instance, if you're hearing voices that aren't being spoken by somebody, like that's a positive symptom that should not be there, right? Some of the paranoia that comes along with that too. Negative symptoms are going to be where they have sort of that flat affect. They may have alogia. They can't come up with words when they want to. They can't necessarily have avolitions. They don't want to do stuff. I love the word anhedonia. I think that's like a great like metal band name. That's where you like just don't get like joy out of things anymore. And so then there's the cognitive symptoms, which are more so like they're just, may have issues with memory, executive function, etc. So the cognitive and negative symptoms are more so from that dopamine underactivity in the frontal cortex, which makes sense why they have issues with like making good decisions and learning from mistakes. Whereas the positive symptoms are from that nucleus accumbens, and that's this overactivity. So positive symptoms are from too much dopamine, negative and cognitive symptoms are from too little dopamine, okay? The double-edged sword here is that our old school medications, the ones that we use for a long time, they just dealt with the dopamine overactivity. So they basically dealt with the positive symptoms, but they made the cognitive and negative much worse. So it's like, okay, well, it's great you dealt with the positive, but now they have even worse flat affect. They have even worse memory impairment, all that stuff. So that was the challenge with some of the first initial medications we have. And we'll talk about some of the second generation benefits we'll get from that. So pharmacologic therapy is super key for these patients here. Typically, you want to be most assertive during the first 5 years before they've had a lot of sort of deterioration from a psychosocial standpoint there. And again, you're trying to focus on the symptoms your patients are having to get an idea of which medications you may want to focus on or which symptoms you want to focus on treating there. So if they're having more of the positive symptoms, maybe more focus on that versus the cognitive and negative stuff. And it can take some time to get an adequate response, maybe even up to 3 months in some cases. So ideally, we would like them to have, avoid undesirable side effects. We're going to see these medications are particularly side effect prone. as we'll see here. We also want to make sure we can get them out of the hospital or keep them out of the hospital by improving quality of life and decreasing costs for them. And again, try to achieve best compliance possible. There's some ways we can try to do that to where the patient doesn't really have a choice to be compliant. I'll talk about that in a few moments, but that's one way we can try to deal with that. And obviously minimize the recurrent episodes as much as possible. So what are we going to do? So at first, what we're going to be our phenothiazine drugs, and these are going to be broadly called the first generation antipsychotics. And so this is why you see a lot of crossover with like tricyclic antidepressants and these drugs here, even some of your antihistamines like prochlorperazine and Phenergan, for instance. They share a lot of similarities in terms of structure, chemical structure, as the antipsychotics. You're going to see a lot of crossover in terms of some of the side effects that we're going to see with these medications here. But the main mechanism of action these drugs are going to have is D2 receptor antagonism, right? That's mainly to block the effects of dopamine in the nucleus accumbens to deal with the positive symptoms. So if you have a patient who is acutely psychotic, they're going to harm themselves to get the voices out of their head or whatever the case may be, how they're presenting. If they're at risk, like this is where you go to things like your Haldol. Like I'm going to show you the list here in a moment, but when you think about an acutely psychotic patient, like those are the symptoms you got to deal with right away. And that's where these medications are going to come into play here, as we'll see just a little bit. As I mentioned, they're going to worsen the negative symptoms and the cognitive symptoms as well, because you're getting even less dopamine activity in the frontal cortex where they're already lacking it to begin with, right? So again, you're decreasing it here, but also decreasing it in the frontal cortex. Overall, just too much diminished dopamine activity. So those, and again, it's good because maybe they're not a danger to themselves or others anymore, but also they're going to have worsened negative symptoms there. So, overall, hopefully got some benefit from it, but it's not the most advantageous. And so that's why these drugs were limited in terms of their overall utility, as we'll see here in just a little bit, especially when you look and compare them to the second generation agent. So what we're going to find is that there are some effects that we see here that are pretty, some of this will look similar to what we saw with Parkinson's, because we're kind of inducing like a Parkinson's-like effect here because we're decreasing dopamine activity, right? So one of the things we're going to see is you'll get the seesaw sort of effect here. So first thing is going to be with prolactin. Patients who have this depressed dopamine activity, if you decrease dopamine activity, you're going to see an increase in prolactin. That means you can develop things like gynecomastia, you can have menstrual irregularities, may have fertility issues, things like that. So that's going to be one issue that comes about from decreasing dopamine activity. Other thing is going to be is by blocking the dopamine antagonism, you're going to see things like increased acetylcholine effects, just like we saw with Parkinson's. So things like resting tremor are possible. And the other big thing we're going to see more acutely are going to be what we call the extrapyramidal side effects. This again is going to be basically a Parkinson's-like effects because you're blocking dopamine in the caudate putamen, just like we saw with patients with Parkinson's. You're going to get the motor rigidity, you're going to get the tremor, you're going to get the catatonia in most severe cases, but they can have that shuffling gait, the hypokinesia, all those things we would expect to see. Also really interesting is you can develop these acute dystonias. These are sort of involuntary muscle contractions. You typically see this like in the face and the neck and the tongue, to where they basically get frozen with their face in a grimace, or they may be sticking their tongue out or something like that, and they're kind of stuck in that way. So ideally, you want to be really careful with this. I've had a few cases like this that have popped up. I actually had one case where a 10-month-old was presenting to the ER. Basically, there's a term called opisthotonus. You can Google that. There's a really good painting that demonstrate that. I mean, I can actually show you just to drive it home. But basically, it was there was a patient who was 10 months old. The mom had a history of schizophrenia. I'm trying to find the actual painting, because that actually looks pretty good. Here, I think here it is. So if you go and look at this picture up here, you get this really bad back arching, and basically this 10-month-old had gotten into his mom's antipsychotic medications and developed this really severe back arching because it basically got a full adult dose right away. And so kid was in awful pain, screaming bloody murder, got brought in. And we're going to see there's really good ways to treat this, but this is just an example of the dystonias that you can develop from use of these medications. So not an ideal thing at all. Yeah, so it can kind of be a similar thing, even though the mechanism is different than with something like tetanus, right? So, Yeah, so someone was asking, can you do a quick summary on the relationship of dopamine to acetylcholine? So just imagine a seesaw sort of thing. If you have good dopamine activity, you should have little extra acetylcholine activity, and vice versa. If I'm blocking dopamine, I'm going to see more acetylcholine, which leads to that resting tremor. Remember, that was one of the big issues with some of the more early presenting Parkinson's patients, is they lack that dopamine such that they get more acetylcholine activity, right? That's cause of the tremor there. So one goes up, the other goes down, basically, is how that'll go. So, the extrapyramidal side effects, the EPS, the dystonias, those are the really big things we're worried about seeing with some of these medications. And you can even get some really more severe versions of that, which I'll talk about in just a moment. An interesting one here, I talked about akathisia before. That's that really severe restlessness and agitation where they just feel like they have ants in their pants. They can't sit still. They just need to get up and move around. I feel like I had this when I had my wisdom teeth taken out. I'm pretty sure I got propofol. I was too young to kind of remember. I just remember a milky white substance they were infusing into me. But I remember when the nurse or whoever was trying to get me up to put me in the recovery room, I just wanted to like get that person off of me as fast as possible. I almost felt like I was going to punch him, but obviously I was too sedate to even do that. But I just felt horrible, right? So you can see with other medications, but this is particularly noticeable with your dopamine antagonist. Another consequence you're going to see with like really long-term use of these first-generation antipsychotics, and this is a problem with the first-gen ones, is something called tardive dyskinesia. This is where by decreasing activity of the dopamine receptors for a long period of time, it can actually lead to this dopamine receptor upregulation, and they actually get really hypersensitive to the effects of dopamine. So they end up developing these like unintentional movement patterns that you're going to see there because their dopamine receptors are just way too sensitive. And you can look up some videos of this, but you can see things like they'll have like chewing and licking movements. They'll just have, like unconscious. They'll just sit there and go, or they'll stick their tongues out or things like that. And again, there's videos you can look up. It's pretty wild to see. And unfortunately, it's not really reversible. But for a long time, this is all we had to treat these patients. It was really sort of a double-edged sword there. And it was basically related to how long that they had been treated for it. And this is something you could have seen earlier with Reglan, with metoclopramide, because it also blocks dopamine receptors. This is something that could develop for like cancer patients that were receiving Reglan for high doses for long periods of time. Unfortunately, this is not the same as dystonia. It's a different mechanism, right? This is more dopamine hypersensitivity. So they don't get treated exactly the same. And in fact, this might actually, if you treat it, extrapyramidal symptoms or dystonia, if you use that type of treatment for tardive dyskinesia, you make it worse. But I'll talk about what those treatments are in a little bit. So the other problem with the antipsychotics, besides just their dopamine blocking capabilities, is they also, very similar to the TCAs, have sort of other myriad effects at various receptor subtypes. So for instance, like alpha-1 antagonism, right? So you can see dizziness, postural hypotension, and whatnot. Remember the mnemonic we have for antimuscarinic symptoms. This is going to happen here too, right? Now, what's interesting is you're going to see that a lot of the extrapyramidal symptoms and the more so the dystonias, they actually develop from that extra acetylcholine. So, in fact, by using something that has more antimuscarinic activity, it's actually good for that. You actually get a little less of those EPS and get more so less dystonias. I'll kind of differentiate those in just a little bit, but they're actually going to be worse for tardive dyskinesia. Someone says, or Brian says, does the dopamine receptor upregulation only affect motor movements, or could it theoretically make someone more at risk for generating an addiction to opioids or something like that? I don't know that it has any effects on that necessarily, because I'm trying to think. I'm not aware of any correlation between that. As far as I know, it's really just the motor patterns that are being affected there in terms of like movement and things like that. But I'm pretty, as far as I know, the mesolimbic pathway is not really affected by that. So not sure why that is, but just something we noticed. They'll also have some histamine receptor blocking capabilities, so sedation, waking. So you can see some of the similarities between the TCAs and these first-gen antipsychotics, because structurally speaking, they do share some heritage there, and so it makes sense why they would have some crossover in terms of their activity at various receptors. Obviously, TCAs don't have the dopamine blocking capabilities. These drugs don't block reuptake of serotonin and norepinephrine, but you can see some of the other similarities between like blocking muscarinic receptors, blocking histamine receptors, etc. Right? With these, you do want to be careful. They can do things like prolonged QT. We're going to see, due to the anticholinergic effects, you can see tachycardia, and they can also cause some conduction delays of sodium channel blockage. Okay, so you do want to be careful with these, especially if there's like an overdose, because you can see a variety of different effects on EKG you'd be concerned with. Okay. Now, the worst thing that can happen to these patients, and this is typically seen with the really high potency D2 blockers, right? So when I say high potency, you're going to find that when you look at the list of first-gen antipsychotics, that they kind of go from like low potency to high potency. I'll make sure to differentiate between those two varieties there. But the higher potency that they are at blocking D2, the more likely they are to cause dystonias, and the more likely they are to cause this what we call neuroleptic malignant syndrome, or NMS. I would never see NMS, I think No Man's Sky, but that's besides the point. But like haloperidol and fluphenazine tend to be the most common culprits for this. And so, but it can happen with any of them, right? Any of the first-gen antipsychotics. The problem with it is that they can develop, and this actually looks a little bit like serotonin syndrome, but they develop hyperthermia, altered mental status, hypertension, and they can develop what we classically describe as lead pipe rigidity. And that muscle contractions, especially if they stay contracted for a long period of time, can lead to things like rhabdomyolysis. All that myoglobin leaching out into the bloodstream can clog up the kidneys, and they can have renal failure associated with this. And I've seen one like really good case in person of NMS, and it was this guy, and it was so wild because he had, had switched his medication, the dose had gone up or something like that. Like it was unintentional sort of effect. He's in the ER, and his arms were just kind of real tight up against his chest, and I was like, well, just relax your arms for me. And I was trying to move his arms, and he's like, I can't. And I'm just like, well, what are you talking about? You can't. Just relax him. And he's just like, I physically can't. It was really freaking him out. So we'll talk about some ways we can manage that as well in just a little bit. But the muscle breakdown issues is the thing that we really are concerned with, along with the hyperthermia for those patients. So here is a list of all the first generation antipsychotics. Boy, there's a lot of them. Don't you notice? The ones I've highlighted here are the ones that I think are probably more so a little bit more commonly encountered in the clinical standpoint. So these are the ones I would like you to memorize. So the ones in yellow here, so like chlorpromazine, thioridazine, prochlorperazine, which we've encountered that before with like anti-nausea stuff, fluphenazine, and haloperidol. Those are the big ones. What do I want you to know about them from this chart here? Basically, keep in mind that there's going to be a balance here between how high affinity they have for the dopamine receptor, and then conversely, how much affinity they have for things like the muscarinic receptors and alpha-1 receptors, etc. So what do we notice here? Well, I already said that haloperidol and fluphenazine are going to have the highest potency at the D2 receptors. Notice they have 4 pluses here. Do I care if you know if it's 3 or 4 pluses? Not in particular, but what I want you to notice is a relationship here where they don't have a whole lot of anti-muscarinic or anti-alpha effects, as compared to something like chlorpromazine, which is Thorazine, which is that one I mentioned in that movie, Beautiful Mind. Notice here it has relatively low dopamine potency compared to something like haloperidol or Haldol, but it has much higher activity against antimuscarinic, alpha-1 receptors, and histamine receptors, okay? So generally speaking, that's kind of the balance there. If it's high potency D2 receptor blocker, it's going to have lesser effects at the muscarinic, alpha-1 receptors, and all that. If it has lower potency at the D2 receptors, it's going to have higher affinity for muscarinic receptors, alpha receptors, and all that. So you can kind of guess what the difference in the side effect profile is going to be depending on which agent that they're on, right? So for instance, if someone gets a dose of Haldol and all of a sudden they have a dystonia, they lock up, that's much more reasonable to assume because of that's what the drug does. It's much more potent at the D2 receptor. I would expect that less likely to occur for someone getting something like compazine or something like thioridazine, because it just has less propensity to cause that because it has less affinity for that D2 receptor. Okay, that's kind of the balance there, is what I want you to understand. And if you had a patient who had, say, an acute dystonia due to something like haloperidol, you could switch them over to one of the ones that have a lower potency, and you'd be less likely to get that effect, because actually, by blocking the muscarinic receptors, it helps to relieve some of that acetylcholine effect that you would normally have with Haldol blocking dopamine, right? So again, they kind of counterbalance one another in that way. So that's kind of the things I want you to think about when looking at a chart like this. And again, I was gracious enough to not make you memorize the entire list, because honestly, I don't run into these very often. The ones that are here are the ones you see pretty commonly. Honestly, probably prochlorperazine and haloperidol, the ones I see used clinically most frequently, at least in the ER sort of setting. Someone said, can you elaborate on what you were speaking about in regards to antimuscarinic effects? Absolutely. So remember, the antimuscarinic effects, you can go back to that mnemonic we use of mad as a hatter, blind as a bat, red as a beet, hot as Hades, and dry as a bone, right? And tachycardia, the heart runs alone, right? Thank you, benevolent overlord. Never been referred to as that, but it has a nice ring to it, so maybe keep that up. Just kidding. So anyway, yeah, so that's what I'm really referring to there. So if you can remember that mnemonic, it helps you to memorize sort of the common antimuscarinic effects you'd be running into here. So if I had someone who's on something, for instance, like chlorpromazine, I would expect them to have more of the constipation, the dry mouth associated with that. I'd expect them to have issues of orthostatic hypotension because of the alpha-1 blocking effects here. I'd expect them to have more sedation and weight gain associated with the histamine effects, right? So you can kind of gauge how severe these side effects are going to be based on overall relative propensity for it to block dopamine activity. That makes sense. Now I'll give you some examples here going forward in a little bit. But one of the big takeaways here is that the more high potency they are at D2 receptors, the more likely they are to cause dystonias and NMS, right? If there's one takeaway you get away from that, that'd be one I think is important. So this is another way you can kind of organize this, and it kind of speaks to exactly what I was saying just in the last slide as I was rambling on there. What I want you to focus on here are, notice the first generation or typical antipsychotics are going to be listed here in the top part of this. We're going to get into the atypicals here in just a little bit. That's our second generation drugs. I want to focus on how you can see how things like the high potency drugs, they have less sedation associated with them versus something that has a low potency, right? Because they have more antihistaminic action, more antimuscarinic action. So those are kind of the balances between those I want you to kind of focus on or kind of notice with that. So hopefully that makes sense. If not, let me know. And again, just look at the ones that I listed on the previous slide as the ones I'm going to expect you to memorize. Okay, so the first gen drugs, very good for positive symptoms. Usually you're going to find that side effects can lead to discontinuation, especially if you have concerns like tardive dyskinesia, things like that. And again, select the agent based on their symptomatology. If they're having more of those acute positive symptoms, I may be more likely to use a higher potency dopamine blocking agent, especially if you're like in an ER setting and they're being brought in by police officers and having an acute psychotic break and they're a danger to themselves and others. That's where you can bust out the really high potency ones, and that's going to really help knock that down pretty quickly there, right? So again, kind of think about how these drugs can be used in the clinical situations based on their side effect profile and how they're acting there. Brian's asking, how come Haldol is used to knock out unruly patients in the ER even though it has low sedation? Because if you think about it, like, why are they being unruly? And a lot of it is to do this overstimulation. And so even though it's low sedation on there, I think that's probably more in reference to, typical like oral maintenance dosing. When we're seeing in the ER, you got like a big IM dose of this stuff. And so even that can still have some pretty sedating effects. So kind of a combination of those two things, I would say, from that standpoint. It's a lot bigger bioavailability, hitting the system pretty quick. Because imagine, too, think about logistically, if you've never seen these patients who are being a little more unruly, as Brian so succinctly put it, consider that, like, can you get them to take something oral? Like, well, no, they're probably going to bite your finger off, right? Can you get them to get can you get an IV started? That's going to be unlikely, right? Unless they're in restraints and you got them really held down well. So IM is frequently the best way to get a medication into them. You can at least get someone to hold them down long enough to get an IM shot in, and then you'll see they can chill out. And then you can do whatever you need to. If you need to do a medical evaluation, get an IV started, etc. So that's kind of the mindset that we're dealing with patients in that sort of situation. We don't like to do chemical restraints, but sometimes you have to, It's maybe a dumb question. No such thing. But are muscarinic and anticholinergic and antimuscarinic effects the same? So I probably use the two interchangeably. Anticholinergic refers to anything blocking acetylcholine, Most frequently, people are referring to the antimuscarinic effects, though, right? But anticholinergic drugs could also affect nicotinic receptors as well. So, anticholinergic is the more broad sort of categorization. Antimuscarinic is the more specific to those types of receptors there. But again, clinically, you'll hear people say the two interchangeably. We most often, that's most frequently what we're talking about with drugs. Anti-nicotinic drugs really only come into play when you're doing things like, paralyzing somebody. And I'll get into that in the surgery section a little bit later on. Okay. Someone said, can you elaborate on why you were speaking about in regards to antimuscarinic effects? Which part specifically? I guess, the mnemonic. Remember, the mnemonic goes over all the common effects you're going to see with that. And again, what we're talking about here is, what side effects can you expect these drugs to cause, right? So, which ones are more likely to cause constipation, Haldol or chlorpromazine? Well, probably chlorpromazine because that one has more strong anticholinergic effects, as an example. So that's what I would say to that. If I didn't answer your question, feel free to write something else out. So it's a lead pipe rigidity seen with potent D2 blockers from an increased acetylcholine. My understanding is it has a lot to do with that. You get overstimulation of those nicotinic receptors because you could paralyze the patient. You can give them something like a rocuronium or succinylcholine and paralyze them. That's not ideal because then also their diaphragm is paralyzed and they can't breathe anymore. So then you have to intubate them. So we'll look at some other ways we can treat that here in just a little bit. But that's kind of the thing that I think of in terms of mechanism that makes a sense to me. All right. Anyway, so as I mentioned, you'll pick these agents based on kind of their symptomatology. But how do we treat the side effects? So for EPS, extrapyramidal side effects, this includes any dystonic reactions. It includes anything like akathisia. These are treated with anticholinergics, right? And so specifically antihistamine is done most commonly. And what do you notice here? This looks pretty similar to how you treat that resting tremor that you saw with Parkinson's patients, right? Because patients are having too much acetylcholine activity, so you give them something like diphenhydramine, and it fixes it for the Parkinson's patient. Same thing is fixed here as well. So diphenhydramine, trihexyphenidyl, benzodiazepine, all can be used to help deal with that. So that little baby I talked about that came in with a piece of tonus, we actually gave them a big IV dose of Benadryl, and that almost within a couple of minutes had relaxed and allowed those back muscles to kind of calm down, and the baby was much better off. And fortunately, took a nap afterwards because that was an ordeal for them to go through. And for some patients, they may be on these like chronically. They just may take these with their antipsychotics. We actually had a case one time where there was a family. There's I think a mom, a dad, and a son. They had all bought what they thought was, I believe it was, they thought it was brand name Valium or diazepam. They thought they were buying from a drug dealer, and then they come in and they're having like an acute dystonia. So they're all sitting there like, their tongue sticking out and their faces kind of stuck in this grimace. And so what it turned out is that the markings on the brand name Valium actually look very similar to haloperidol. And so they thought they were getting was not what they actually got. And so they end up having an acute dystonic reaction from taking all this Haldol. So we end up giving them an anticholinergic, like some Benadryl, and then actually end up helping to relax the muscles there. And then we gave them a good education to perhaps don't take drugs from drug dealers unless they're a licensed pharmacist, and then maybe it's okay. Maybe sometimes. And if this still isn't fixed, you could try using benzodiazepines as well. They still have some muscle relaxant capabilities, you'll see. So that's actually a decent treatment for that if the anticholinergics are no good. Someone said, so based on the last chart, how potency drugs or low potency drugs have low EPS risk and high potency drugs have higher EPS risk? That is correct, right? Then the sedation is inversely related. Low potency, high sedation, and vice versa. That is more succinct than how I put it. Absolutely. That's exactly right there. So that's correct. That's the understanding you have of it. You're doing pretty good. Someone said, would you try all of those anticholinergic drugs first to see if they work for the EPS, or would you try one and then try a benzo? I would do it based on what I have available to me. If you're like in a typical ER setting, like everyone has IV Benadryl available, I'll probably bust that out first. Although for more chronic use, you may see more cases of patients being on like trihexyphenidyl or benzodiazepine. I've seen probably more patients chronically on cogentin, mainly due to it having a little less sedative sort of effects. But and again, most of the time, which one do you go with? You go with whatever you have available. And so if I had a patient who's coming to the ER that was having an acute dystonic reaction, I would go ahead and try the Benadryl first, and if that was still not responsive, I would then try benzo. So probably use some Versed or lorazepam or something like that. Great questions, you guys. I love how engaged you are being. I guess it could just be one person writing all the same questions, but that one person, very engaged. I like it. Anyway, so for the tardive dyskinesia, remember this is not the same mechanism as why patients get dystonia, right? So this is actually dopamine hypersensitivity, if anything. So you want to avoid anticholinergics because it actually just makes it worse. And then there's not really a whole lot you can do for it. You can try what they call drug holidays. Now, some of you might think drug holidays are what you do at spring break and you just go and buy a bunch of stuff off the street. But those are not the kind of holidays we're talking about. These are the kind where you are actually taking a vacation from the drugs and you kind of give some time to try to relieve that pressure of the drug on the body over the long term, even though knowing that you may have, recurrence of your symptoms related to that. So not ideal, but you kind of do what you had to back in the day. Ideally, you could switch into a second generation agent, which is going to ameliorate a lot of these issues. Tardive dyskinesia is basically not a concern for patients getting a second gen drug for the most part. So anyway, if you had a patient who truly had NMS or neuroleptic malignant syndrome, basically you stop giving the drug. This should be pretty obvious. And then you got to cool the patient down just like you would with serotonin syndrome. It looks very similar. You hydrate the patient, and then you can utilize a drug called dantrolene. So this is something, if you ever worked in like surgery or the ER, you've probably heard of. Now I'm trying to blank. Why am I blanking on the term all of a sudden? Get it with malignant hyperthermia. That's what I'm thinking of. So there's a condition you can develop after receiving certain type of anesthetics or certain paralytic called malignant hyperthermia. This is actually treated very similarly to that because the actual presentation is very similar. But basically, you can get them a drug called dantrolene that works as a peripheral muscle relaxant. And of course, I could have just looked at my slide and saw the name right there, but of course, I was not looking at that. Shows you I just don't read off my slides. If some of you may disagree, but I don't. Another way we could treat that too would be by using a drug called bromocriptine. This is actually, we saw this previously in the treatment for Parkinson's. This is basically a dopamine receptor agonist. This is basically replacing what they're missing by activating those dopamine receptors there. So that's how we would manage that. Marley was saying, so with drug holidays, you would go completely off the meds? Yeah, so you try to titrate off and try to go off the meds for a period of time, maybe a couple of weeks, maybe a couple of months, and then you can restart the medications over. Someone said you have to taper patients off these drugs. I would probably taper them just because you could potentially see sort of like rebound of their symptoms if you went off of it cold turkey. And that's what we see a lot too in these patients, where if they are on their meds for a little while and then for whatever reason they say, okay, I don't need this anymore, and they go off of it, that's oftentimes what leads to relapse of their symptoms, and they can oftentimes end up in an acute, kind of a bad place, and can end up in the ER, unfortunately. Yeah, so it depends on the patient how sensitive they are, Marley. So if you can taper and you're monitoring along the way to see how they're doing, then that would be ideal. But for some patients, maybe they couldn't tolerate a taper, depending on how severe their case happens to be. It's very individualized. It's not like a one size fits all sort of treatment for that. Yeah, good questions. This is a slide I'm not going to go through over again, but these are kind of what we talked about. It summarizes basically what we were discussing there. Again, you get an idea for how to treat these, know which drugs are more likely to cause some of these effects. So for the most part, the high potency drugs are more likely to cause acute dystonias, the Parkinsonism, all of that. And yeah, like I said, how to treat it. That's going to be what we want to know there. Again, so I think it's a good slide to kind of compare all this stuff there. So anyway, getting into our second generation antipsychotics. These are also called atypical antipsychotics. Their benefit here is that they have really few extrapyramidal effects, so less EPS, and less prolactin effects. You're going to get less gynecomastia and menstrual irregularities and all of that. And they're also more effective for negative and cognitive symptoms. They also have less tardive dyskinesia risk with prolonged use. So as far as I'm concerned, these should be first line unless contraindicated. And you're like, well, why do we even have the old ones available? Because some people still need them if they are unresponsive to the second generation antipsychotics. But when these came out, they really kind of revolutionized treatment for schizophrenia because of all these benefits that they have there, as we'll see. Someone said, would pramipexole work similar to bromocriptine for NMS? It may potentially do the same thing. I just know most references say just use bromocriptine. I think more places probably carry that on a routine basis, like in a hospital sort of setting, because you'd be treating, this is more of an emergent situation. You'd be treating more like an ER ICU setting. So that's what I would say to that. Let's see here. So their mechanism, so they have a little bit of affinity for blocking dopamine receptors in that striatal tract down in the nucleus accumbens. So have a little bit of activity there. But the big thing they do is they actually block serotonin 2 receptors up in the frontal cortex. What that's going to do is going to basically allow for more dopamine activity in the frontal cortex, and that's going to help to regulate how much dopamine activity is happening in the nucleus accumbens. Okay, so basically trying to reestablish that normal function such that you have improvement in the cognitive and the negative symptoms, and you should have some regulation of the positive symptoms. Now, you may not have as good of control of the positive symptoms as you would with something like a Haldol, but it is still better than nothing for sure. So basically, instead of just blocking the dopamine here, dealing with the positive symptoms, and then also blocking it here, worsening the negative symptoms like you would see with a typical first-gen antipsychotic. Instead, what we're doing is we're decreasing activity right here at the serotonin 2 receptor, and that's going to allow for more dopamine here to be allowed to flow freely. And then by activating this D3 and D4 receptor here, it's going to help to inhibit the dopamine overactivity here, right? So it's basically helping for this circuit to work more effectively to reestablish normal dopamine levels, okay? So that's basically what we're getting at from that. Someone was saying, if second gen is better for negative and cognitive symptoms, is it not as good for people with positive symptoms? To a degree, yeah. So you'll still see for like acutely psychotic patients, like in the ER setting. I always go back to that because that's just my home. But when I think about that, could it be less effective for those positive symptoms? Yes, to some degree, I think it'd probably be less effective for that. But when you're having those really acutely psychotic patients, you could also see that these drugs the second gen drugs are also really sedating. So this can also be good from that standpoint too, to really try to knock those patients down, to calm down enough to where you can do what you need to do with them. So that's why you'll see a few second-gen drugs being used in those emergent settings, but in a lot of places you'll still see things like Haldol being used in that situation as well. So really just depends on who the providers are and what their preferences are in terms of medications to use and what their normal protocols are. All right, so the downside to using the second gen drugs are going to be the adverse effects we see in terms of like the metabolic consequences of them. And so this is going to be a challenge here. So you're going to see that weight gain's a huge thing with these. You'll see highest incidence with things like olanzapine and clozapine, and lowest with some agents like ziprasidone and aripiprazole. Typically, if you start to see your patients that had more than the 5% weight change, you want to go ahead and switch them out to a different second generation antipsychotic. I've seen some patients who really did not do well with any of the other second gen drugs and ended up on olanzapine, and they gained like 20-30 pounds like no problem. Like you just put on weight like with no effort on these medications here. So be careful with these two. Olanzapine is probably not going to be a first line recommended one just because of the weight gain issues, which also feeds into things like glucose intolerance, right? So you're going to see more incidence of diabetes, especially with clozapine. You're going to see worsened effects on their lipids, a lot of negative effects here in terms of the endocrine system. Someone said, so is there technically no drug that would aid in treating all the category of symptoms? Do you have to kind of give and take what you can actually treat? I would say for most patients, the second gen drugs will do just fine. If they were having still really severe positive symptoms in spite of a second generation drug, then yeah, maybe you need to switch back over to a first gen antipsychotic. But for the grand majority of patients you'll run into, the second gen drugs will work just fine for both their negative and positive symptoms there. So again, it's individualized, but for majority of patients will do just fine with a second gen drug here. Someone said, just to clarify, first gen is better for treating positive symptoms and second gen is better for negative symptoms. Yes, overall. Now, the second gen drugs will still work for positive symptoms, maybe just not to as great of an extent. Okay, but again, that trade-off is usually worth it for most patients there. Okay, so some other things you'll see here. One, clozapine. This is actually another drug that has a REMS program, just like Accutane does, and this is for agranulocytosis. So it's like a 1% incidence, and so you actually have to do things like getting CBCs done like weekly while they're on this drug, and they can't even refill it until they've shown that they have, show that their white counts are looking good. So again, clozapine is going to be something that you reserve for like the most treatment resistant of patients because it's just such a dangerous drug from that standpoint. Because if they're not getting monitored and they're taking it, they develop this and they can die from secondary infections very easily if they're running out of their granulocytes. So that would be something I would definitely hold off on. But this is good to know about this drug because it is pretty unique to it, right? With cardiac effects, you can see QT prolongation, so we certainly worry about that, especially if they're taking other medications. Like, if I had someone on, something like ziprasidone plus citalopram for their depression, you could see, again, synergistic QT prolongation. That's why I'd want to check things like EKGs for those patients there. And then with orthostatic hypotension, this is more so you're going to see it with like the really heavy duty, like IV doses. You get to like acutely symptomatic patients there. But you can also see this in the elderly as well, who are just more prone to that due to reduced sort of physiologic reserve. So, and then they do develop some tolerance to this over time. So that's something that does improve. Now, one of the things you run into is this black box warning, and oftentimes what has been done in the past is you'll have these elderly patients who are maybe hospitalized or taken out of their normal home. They're on the unit, and all of a sudden, sun starts going down. What do people get when the sun starts going down? Well, they start sundowning, right? And basically, it's like they're in this unfamiliar environment. They're surrounded by unfamiliar people. Maybe they have this like IV that's in place, and they're in pain, and they're just not in the normal environment. And so they start to get kind of acutely agitated, and that's something you can certainly see with some regularity. And for some people, they think that, okay, well, maybe it's their dementia is related to this, but they're agitated, so they go ahead and they just give them a second-gen antipsychotic and say, okay, well, I'll chill them out. Yeah, it'll knock them out for sure, but they've actually ended up seeing that there's an increased mortality in elderly patients who are being treated with these drugs that, relate to this dementia-related psychosis. So basically, I would avoid using antipsychotics in order to treat dementia symptoms because it does see that it kills them more often, unfortunately. So that's one big black box warning you'll see there. A lot of these tend to be pretty sedating, so especially clozapine, olanzapine, and quetiapine, which is Seroquel. And I'll show you the comparator slide here in just a little bit. Sometimes by dosing them at nighttime, that can help them sleep throughout the night, and that helps to deal with some of the grogginess throughout the day that they'll be experiencing. And then a lot of these will still have anticholinergic effects. So in particular, clozapine and olanzapine here. So dry mouth, constipation, all that normal stuff we talked about, which you saw with the low potency first-gen drugs there. And then in terms of seizures, it's not likely to happen, but clozapine and olanzapine tend to have a greater risk. So overall, you could probably take away from this, wow, clozapine shows up for a lot of these, olanzapine shows up for a lot of these. Perhaps these are not the first ones I wanted to go with. And you'd be correct if you made that assertion there. But in terms of drug interactions, there's not a lot that you're going to see in terms of like pharmacokinetic interactions here, which is at least one benefit. But you're going to see that if they're on multiple meds that cause sedation, that's going to be worsened. If they're on blood pressure medications, you can worsen orthostatic hypotension. So those are kind of the general interactions you're going to see there. And I see this quite frequently for a lot of like overdoses where they may have overdose on blood pressure medication and antipsychotic, depression medications, so you get to see a lot of these drugs all work synergistically to cause pretty severe effects. In terms of if this was used in addition to other dopamine blocking drugs, you do increase your risk for extrapyramidal symptoms. So things like Reglan, things like Phenergan can both do that. So you'd probably want to avoid mixing and matching those drugs together. Someone said, can you give examples of positive and negative symptoms? Yeah, so positive symptoms, I always think about it as things that are there that should not be there. So like paranoia, if they're hearing auditory hallucinations, if they are, I guess you can see auditory hallucinations, but they're having auditory hallucinations, if they are having like delusions of grandeur, all those type of things that should not be there, those are positive symptoms. Those are the ones where people can get themselves into trouble thinking that, they need to harm somebody or that the voices are telling them to do something dangerous. That's the stuff that can be sort of life-threatening for them and ends them up in usually an ER for treatment. The negative symptoms are things that should be there but are not. So like they don't have a lot of motivation to do anything. They don't feel enjoyment out of anything anymore. They can't come up with words. I guess I have some alogia after doing three consecutive lectures with you guys. But those are things that should be there but are not. So those are negative symptoms. Hopefully that makes sense. All right. So here's a good list here of all the different for second generation antipsychotics here. So all of these are really at play because these are really a popular set of drugs to use for a lot of different conditions. So you can see these used for bipolar disorder. You can see them being used for depression that's resistant to SSRIs. You can see a lot of different uses for these. So this is why I do say, yeah, you should be able to recognize all of these as their second generation antipsychotics here. It's a little bit of small print, but you can expand that if you need to. And again, I don't expect you to note necessarily whether it has 1 star, 2 stars, whatever the case may be. But if I mentioned on the previous slides, I would at least know that those are the more likely ones to cause some issues. All of these can be sedating, but in terms of like weight gain, sedation, anticholinergic effects, like clozapine and olanzapine tend to be kind of the worst offenders there. So, if you look at just across the board, a lot of stars here, I'd probably avoid using these unless they just didn't really respond to much else. But some of these you actually find they have pretty good effects here. So something like aripiprazole, very popular to use as a first-line drug, because it has very relatively low incidence of side effects compared to some of the other ones. I know things like, where's risperidone? Risperidone tends to be pretty good for the most part, but you can see some of these even have higher abilities to cause hyperprolactinemia. I'm not going to grill you really on those specific differences, but if I mention them on the last set of slides, then yeah, I'd want you to know that. But this is a good comparator slide here. And again, always new ones coming out, it seems like, just due to the lucrative nature and the number of people you could potentially put these patients on. There's a couple of other ones these are some of the newer ones that are just coming out. This is probably even outdated, even done the past couple of months. So, but like bexipiprazole, iloperidone, cariprazine. These are things that you may not necessarily see all that often because they are quite so new. And again, sometimes there is a little bit of, it takes time for these to get into the regular rotation for providers just because you use what you're used to because you have experience with it, and why change it if your drugs are working, unless there's some significant benefit. And again, just to put the slide on here again, just to compare the side effect profiles between your high and low potency first gen drugs versus the atypicals, and you're going to be able to see that the side effect profile is probably pretty similar between atypicals and the low potency agents for the most part, just less EPS risk, less hyperprolactinemia, so those are kind of the general things I want you to be able to kind of compare and contrast between these agents here, right? In clozapine, olanzapine tend to be pretty much worse in terms of like weight gain and diabetes and things like that. So just something to note. In terms of monitoring for these patients here, the big things are going to be things like weight, blood pressure, typical things you're going to be measuring for these patients anyway. And certainly looking for antipsychotic side effects they may be experiencing. So specifically EPS and tremor, dystonias, things like that you'd be looking for. So anyway, so for acute treatment, typically what I'd say for these patients is that if you need to do something immediately, like decreasing positive symptoms, then using like a first-gen drug may be reasonable. It just depends on how kind of severe of a case you're dealing with when it's first discovered, right? Because it may be like when they're having an acute break as when you're first discovering they need this. Benzos can also be useful to help out with calming and sedating the patient as well. So just, you can utilize, sometimes you'll even see the combo where they may do like Ativan plus Haldol or something like that for really severely agitated patients. And you can titrate as tolerated, right? See how bad the side effect profiles are for those patients. See how the efficacy is going. And remember, patients are going to respond differently from one another. They are fairly unique in that way. So you may need to switch around within the class to find something that works for that particular patient. Now, as I mentioned, in terms of compliance issues, which is another common thing you're going to see with these patients here, there's actually a lot of long-acting injectable forms, call it depot forms of the drugs, where you can basically inject it intramuscularly, and it will allow for the drug to leach out into the bloodstream over the course of usually months. So, for instance, something like haloperidol, I think it lasts like 3 months or so, and then come back. So even if they do miss their shot. They still have some lingering drug that's around. It has a nice natural taper to it. So there are some benefits for that. This would not be something I'd just right off the bat start using. I'd probably try using oral treatment first to see how they respond to it. And if they're a good candidate, they respond well to it, then you use the injectable form. Because otherwise, you start them off on something like haloperidol and they have a dystonic reaction, there's no real way to get that drug out of that patient. It's kind of there. So this is why you'd want to use this once you have a good track record with a particular drug in a patient. All right. So just to give you an idea of kind of an algorithm on how you might consider treating these patients here, as I mentioned, aripiprazole and risperidone, even ziprasidone, tend to be pretty reasonable second-gen agents in terms of side effect profiles. So most people will end up starting with these for those that are treatment naive. So if they're getting the first initial diagnosis here. And if they've previously been treated with something for schizophrenia, find out what's been working for them, what hasn't, and then consider switching around within the second generation category if there's something they haven't tried before, if nothing is really working for them. And then you kind of go down and just see like how they're doing, see if they're really responding well or not to monotherapy. For really severe patients, you consider clozapine, but this is like a last resort just because of the agranulocytosis risk seen with that, right? And then you see how they do. You can try, 2 different antipsychotics if you need to. At that point, once, things are kind of figure out if it's going to work for them, you may need to add on additional agents. You may need to consider treating their depression. You may need to add on things like benzos. Just depends on what their symptomatology is really like. But again, I'd probably not use clozapine if at all possible, just due to the side effect profiles. I'd probably save olanzapine right before that, just because its side effect profile is pretty nasty as well. So anyway, remember, deal with the other things they're having as well. If they have anxiety issues, depression issues, that all needs to be managed in addition to the schizophrenia. It cannot be really treated in a vacuum, unfortunately. So there's that. Typically, if they're going to discontinue, we do want to taper, just like we were talking about before, generally over like 2 weeks or more. And if they start to develop any kind of withdrawal symptoms, some of their symptoms start to come back, then we can restart at a lower dose and then see how they do from there. Typically, if you're switching between agents, you don't want to leave them without any drug. So there are some cases where you can actually taper down off the first drug over 2 weeks, and then you can start low dose on the second agent and then titrate that up. So that way they still have some coverage there, but they're not going to get 2 agents going full blast at the same time and cause a bunch of EPS, for instance. And those withdrawal symptoms can be varied, but it usually includes things like a lot of anxiety, nightmares, insomnia, a lot of restlessness. So those are things we're trying to avoid, but these are things you want to look out for sure. So any questions on that in particular? I think that one got a little complicated in terms of some of the interplay with the different neurotransmitters there, but I think we need to have some time to sit there and kind of ruminate on it. It should hopefully make some good sense. Of course, if not, you can always email me. And remember, I think a lot of people hesitate to reach out to their professors because they don't want to bother them or whatever. But even if you want to just just to send me a message, just say hey, I just want to double check to make sure I got this right. That's perfectly fine. I don't mind helping you out because I want to make sure that you have this stuff down because I don't want to find out when you take the test that you didn't get it. I want to find out beforehand so we can try to correct and go forward with that, right? Anyway, let's talk about something many of you might need for test day, perhaps on a Friday coming up in the next few weeks. Let's talk about our anxiolytics. Someone did have a question here. Someone says, if someone has an acute psychosis with a lot of the positive symptoms, you still go to the second gen agent first. So I've had someone like that. It depends on the clinical context. Like I said, my mind goes to the ER. If I'm thinking of someone who's dangerous to themselves or others, I'd probably either go with an IM injectable. Some places will do things like Geodon or Ziprasidone. Some places will go with Haldol. Just depends on where you're working at, what they prefer. For patient maybe you're seeing in clinic, maybe they have recently been diagnosed or you diagnosed them, I would still probably go the second gen drug and see how that works because the side effect profile is such that this is going to be much preferable, especially in terms of tardive dyskinesia. Look up some videos of tardive dyskinesia. That'd be a fairly miserable way to live, and if there's no way to really reverse it, that's not great for the patient. So yeah, if at all possible, go with the second gen drug as best you can. It may not always be possible for majority of patients. Yeah, I would recommend doing that. You know, as a drug of the choice at the ER I worked at. Yeah, I think you'll find nowadays a lot more people are going with Geodon nowadays. I think a lot of the old school providers, so people have been working for decades and decades, are more likely to go with like things like Haldol. And you'll see that there's almost like generational picks in terms of medications based on how long someone's been working, or you know, where how they were trained is typically how they practice, and they try to pass that stuff down. So it just depends. Just to give you an example, yeah, so tardive dyskinesia can be permanent, unfortunately. They use Haldol for people vomiting more than psych patients. Yeah, see, I wouldn't probably go with that. I'd probably use like promethazine more than Haldol, but interesting. Um, you know, it's funny too, because I'll just give you a quick example. So, in terms of like intubation for patients, which we'll talk about when we get into the ER section later, I remember when we were first opening up Nemours, we had to figure out like, well, what drugs are we going to use for all the different type of stuff, right? And so our head of the ER, he was an older, not older guy, but he'd been working for, you know, a couple of decades now. And so he was like, well, I want to use these two drugs. These are the drugs we always want to use. And they're okay drugs, but they're not like the best. There's some downsides to the medications he wanted to use. And then some of the newer people, like people that just graduated from their PEDS ER fellowship, they were like, I've never used that drug in my entire career, which granted is pretty short, but because they've never used it before, they felt really uncomfortable switching gears to use just because their you know, head guy said to use it. So you'll find that you'll see people are like really hesitant to use certain drugs because they don't like to switch from their normal. You know, it just you'll feel that, especially when you're working, you get into your specialty. There'll be like just a certain set of drugs you use, you know them like the back of your hand, and that's it. And you'll lose a lot of this other stuff. But you know, we teach all of this because you got to be ready for anything when you take the pants, right? Anywho, tangent complete. So let's talk about anxiety disorders. We were mentioning this before. You know, it can go anywhere from generalized anxiety, can go all the way to specific phobias, i.e. pharmacology. You know, it could be lots of different things there. And there's some ways we can treat this, both from more of a chronic standpoint, also in treating the acute symptoms of anxiety, as we'll see here. But it probably has developed from sort of a maladaptive stress response, right? Like a little bit of stress response is a good thing. That's what keeps us like able to run away from like bears and be scared of certain things, which is probably helpful from a survival aspect. But it becomes a problem when it's a really chronic thing that you're always worried about something. You always have that, you know, that just that weight on your shoulders over the long term. And you know, there could also be some other issues, like in terms of like HPA axis abnormalities. You know, having hyperthyroidism can cause, you know, anxiety symptoms and a variety of things like that. You know, there's a lot of drugs that can cause anxiety itself too, right? So you want to consider, are there medications on board that could be causing these issues? So for instance, antipsychotics causing akathisia, we talked about before, digoxin toxicity, a lot of stimulants like cocaine and amphetamines can do this, hallucinogens. If you've ever seen someone have a bad trip, like that is certainly a lot of anxiety component of that. There's another movie reference. There's a movie which most of you probably have not seen. It's called SLC Punk. Stands for Salt Lake City Punk. But a guy was selling LSD basically, and LSD normally comes on like blotter paper. He ended up getting caught in a set of sprinklers, and all of the drugs in his pocket basically soaked through and absorbed through his skin, and all of a sudden his mom turned into the devil. And so I always think about that when I think about a bad hallucinogen trip. But there's a lot of anxiety associated with that, right? Not only that, but actually withdrawal from medications can do this too. So like ETOH, opioids, benzos can be very anxiety inducing. And even being worried about missing, you know, some of these drugs here, being like, where am I going to get my next drink from? That can be quite anxiety inducing as well. Yeah, right. So in terms of treatment, we're going to see that supportive therapy is generally going to be pretty much the top list here. Carlson, can you send me a top 10 must-watch movie list, please? And thank you. I don't know if it's a must-watch, but I'll say medically relevant drug movies, I guess. I don't know if that's the right way to say it either, because then I have to put like Fear and Loathing on there for drug movies, but maybe I'll avoid that. But anyway, maybe I'll make a quick list. Or maybe that would be like a good YouTube video, get some like good engagement and get some good views there. Who knows? As a prelude to my cheese cast, but regardless. So supportive therapy is generally good for a lot of patients experiencing anxiety. If you can kind of talk them down a little bit, that's helpful. We're going to see for acute anxiety attacks, benzodiazepines tend to be kind of our go-to there, right? So if you have someone acutely anxious, say they show up in the ER or something, you can certainly get our benzodiazepines on board. I don't know why you mentioned Bridgerton. Does it have drugs in it? I didn't get to watch the whole show with my wife. She has left me in the dust, unfortunately. But actually, chronically, we're going to see is that management with antidepressants is really important here. So that's why we mentioned that part of treating depression is also treating their anxiety. And so, generally speaking, having antidepressants on board is going to be good for the long term. And we'll talk about some alternative agents to things like Buspar and some of our second-gen antipsychotics as well. Okay. In terms of antidepressants, these are really effective for long-term generalized anxiety disorder. So things like, and you can use SSRIs, you can use SNRIs, any of these are perfectly reasonable. But duloxetine, paroxetine, any of those are fine there. Keep in mind, it's going to be not something that's going to work acutely. Remember, it takes weeks for these things to really kick in. So if they're having an acute panic attack and I give them escitalopram, it's not going to do anything right away, right? Occasionally might utilize a TCA like imipramine, but they're going to have more adverse effects. I'd probably try to avoid that if possible. And again, we don't know really why they work. Probably something to do with helping modulate their stress adapting pathways. I don't know, but it's going to take a couple weeks. And again, you review the side effects for the antidepressants we already talked about before, right? Now, there are benzos. If you recall, we talked about these in terms of their use for treating seizures. This is basically doing the same thing, right? If you're anxious, you're going to be having these neurons that are firing way too actively, not to the point you're having a seizure, but basically by trying to hyperpolarize those neurons, you're going to be able to decrease that anxious feeling those patients are having, right? So again, normally a benzodiazepine will bind to the GABA A channel and will allow GABA to bind more readily and allow chloride to flow in and cause hyperexcitability or try to hyperpolarize the cell is what I should say. You're dealing with hyperexcitability by hyperpolarizing the cells. So we have a lot of these that are available. So I mentioned these here because I think you're going to see a lot of these that are out there, and so I think it's important to be aware of them. Most of them are going to end with PAM at the end, but there are going to be a few exceptions here. So I do want to just make note of that. You have things like alprazolam, which is the ever popular Xanax. People do like the brand name Xanax because they call them Xanny bars, because they actually look like a little, almost look like the eyepiece in Tetris, so that little 4-block thing that you can break off into different pieces. People like to sell those because they're easily recognizable. We have things like chlorodiazepine epoxide or Librium. This was really popular for ethanol withdrawal for a really, really long time. We mentioned clobazam being used for seizures specifically. All these other ones, though, you'll certainly see used for anxiety. And so again, you should be able to recognize these as benzodiazepines. So I apologize for the long list, but I didn't come up with the drugs. Now, the ones I have stars here, the reason why I starred them is because you'll find there's a lot of variability here in terms of benzos and which ones go through hepatic metabolism, which ones go through renal metabolism or renal excretion. Some of them are going to have active metabolites. Some of them are fat soluble. Some are water soluble. What I would like you to know is the LOT benzodiazepines, LOTT. So there's lorazepam, there's oxazepam, temazepam, and triazolam. The reason why I starred these is because these are water-soluble benzos that do not have active metabolites, which means they're easier to clear for patients who have organ dysfunction, whether it be hepatic dysfunction. This is typically better for your elderly patient, right? So if I had an elderly patient I need to start a benzo on, which I'd be hesitant to do just because I know it's not great for their mental status and they're more likely to fall and break a bone or something like that. But if I had to, I'd use either lorazepam, oxazepam, temazepam, or triazolam. Now, if I had a younger patient, I didn't really, had no other health issues, yeah, diazepam, clonazepam, alprazolam, any of those are totally fine. These are really better for the elderly patients or the LOT benzos. So that's why I make note of those. Of course, we use them for all kinds of other things like seizures, muscle relaxant effects, sedation. So plenty of other uses, and I'm sure we'll mention them again going forward with the class here. And basically, when I mentioned the lipophilicity, that does have something to do with how fast their onset is. So the faster they can get up into the brain, the faster their onset's going to be, which can be useful if you're having an acute anxiety attack. You also see that the more fat soluble it is, the higher tissue burden that you'll build up by taking it chronically. That's why it's not great for elderly patients, is because they'll build up these big tissue stores. Even if they stop taking the medication, the effect of the drug will just be around for a really long time, and they can't clear it as easily through the kidneys. So that's why, as I mentioned, lower lipophilicity drugs, more hydrophilic drugs are better for your elderly patients. Like oxazepam is a good example of that, right? Most of these are available PO, but you may see a few used IV. So like diazepam, lorazepam, midazolam, those are typically the IV ones you're going to find most commonly. I'm not going to ask you on a test which ones are IV or PO, but I think it's, as you work, you'll get a sense for which ones come in which forms most commonly. And then we'll see 3 or 4 does metabolize most benzodiazepines, with some exceptions of lorazepam, clonazepam, and oxazepam, right? So notice here, again, lorazepam and oxazepam show up here because they don't have those metabolites to really worry about when going through step 3 or 4. If I had someone with hepatic dysfunction, these would still be good benzos to use for them, right? So keep in mind, those with liver dysfunction or those that are building up active metabolites, those are the ones that are going to have more extended effects, which are, not great for those that are elderly and more likely to fall. Okay. Obviously, the adverse effects include things like CNS depression, so like drowsiness, sedation, all of that. Interestingly enough, for especially kids and some adults, you'll find they have what they call a paradoxical excitation. It's kind of like, I kind of equate it to like when you're drinking alcohol. You think about like when you drink like one drink, like you're feeling pretty good, you're like talking to people, you get that social lubricant action, you're kind of excited almost. That's kind of what they get with the benzo effect. However, when you get to like 3 or 4 drinks, maybe you're getting a little more sleepy and tired and you pass out or something. If I have someone who has gotten a benzo and they're having like excitation and more anxiety because of that, you just give them more benzo and that'll chill them out eventually, which is good. It does cause some memory impairment, just like alcohol does. You have kind of a blackout sort of period after receiving the medication, which is good if they're like going for surgery, or if like they come into the ER and they have a broken bone that needs to be set. Like maybe I don't need them to remember the whole process. That can actually be a good thing there. Start crying around your 3rd glass of wine. Oh, sad drunks are that's sad for you. Just drink 2 from here on out. Or maybe if you drink more, you may have different effects. Who could say? But I would not experiment like that. The other big thing too is to be careful with benzos and mixing them with other depressants. So specifically ETOH is the most common one. You're going to get a lot of synergism there. And in fact, when they talk about like the safety of benzos, they're really safe from like a mortality standpoint. They say the only way someone could die from like an acute benzo overdose is if they got hit with a truck that was delivering the drugs to them. That goes out the window when you're dealing with other depressants, right? So if you have ethanol plus benzos, your risk for things like respiratory depression goes up. People are more likely to die because of that, right? And again, withdrawal can be really nasty here. So especially because there are risks for seizures with withdrawal from chronic benzo use. So this one, you gotta be really careful with. Not only can you get rebound anxiety, but you can see that seizure, which is potentially life-threatening. Just like the DTs, delirium tremens that you get with ethanol, same thing can happen with the benzos. So you do need to titrate off of them slowly if they're going to be on it chronically. So someone said, so would water-soluble benzos be drug of choice for elderly? Absolutely. So I would go with the lot benzos. Those have the most favorable pharmacokinetic profiles for elderly patients. And in fact, there's a list out there called the Beers list, which, I know we're talking about ethanol, but that's a different beers. But he made a list, or this organization made a list that covers all of the drugs that are more problematic in geriatric patients. And I'll talk about this when we hit Jerry stuff later on. But basically, they try to list out all the drugs that are bad in elderly patients. And guess what? There's a ton of them. So it does make it more difficult. But if you had to use a benzo, one of the lot benzos would be good. Someone said, to clarify, can you treat anxiety caused by benzo by giving more benzo? Yeah, that's basically what you would do. Again, it's not common. You would see that paradoxical reaction, especially in adults. But if a kid was having that reaction, you could just give more benzo, and eventually they'll chill out. It has to do with some of the inhibitory effects of benzos on inhibitory neurons, basically. But it's just know that you can always give more, and that will eventually cause sedation for those patients. Why wouldn't you just use the lot drugs as first line, not just in the elderly? Are they less efficacious overall? Sorry, I missed that. No, not necessarily. I mean, you're not wrong to use something like a lot benzo for, say a 30-year-old healthy patient. That's perfectly reasonable. But some of the other ones may have a little faster onset, maybe longer duration of action. some of those may be more reasonable there. So again, when you're working, you may just figure out that you have like, okay, certain go-to drugs for certain conditions. So, maybe for a younger patient, maybe a Xanax was good for them versus older, maybe, using something like lorazepam is better. Just depends on the situation. And ideally, you'd not be prescribing these chronically if at all possible, because again, these are controlled substances. They're all C4s. They're not explosive, but they just have a risk for addiction associated with them. So you do want to be cautious. And again, if you can use them for the shortest period of time possible, that is beneficial. Okay. Now there's buspirone. This is actually a non-benzodiazepine anxiolytic. This actually has no like anticonvulsant properties, no dependence properties, anything like that. So this would be better for someone who maybe had a history of drug abuse, someone who has to operate heavy machinery, something like that. It's maybe not as effective as an antidepressant would be, but you could give it a try if they maybe could not tolerate something like an SSRI, or for instance. And it does take a couple of weeks to really kick in. We don't really know the full mechanism. Probably has something to do with agonizing, at least partially agonizing 5-HT1A receptors. And overall, it's pretty well tolerated. You may have a little bit of dizziness, but not nearly as bad as like a benzo. And it is metabolized by CYP3A4. So this would be like second line to like an SSRI or something for like chronic management of anxiety. What are the 3A4 effects on benzos? Several of them get metabolized by 3A4. So other drugs that inhibit or induce that can lead to drug interactions. And again, when you have elderly patients who are on a ton of drugs, you're more likely to run into those interactions just by chance alone. So now beta blockers are interesting here for use for anxiety. So imagine if you were anxious before a test. So imagine you have to get up at 8:30, or get up even earlier. So let's say you get up at like 6 or 7 for an 8:30 exam, and you're feeling really anxious. You probably don't want to take a benzo right beforehand, because like you're not going to remember all the facts that you memorized the night before, and you may not do very well on the test, especially if you fall asleep at your computer, right? Fortunately, I've not caught anyone doing that on the Respondus browser, but anyway, but you wouldn't want to do that. So if you needed to be able to be like awake and alert and active, but deal with the physical manifestations of anxiety, this is where you can get your beta blockers to come into play. So this can be really handy from that standpoint. And so this is good for like performance anxiety, or like anxiety before a test or something like that. If you're, a musician, or just anything where you need to be physically still present and with it, but you need to deal with those physical manifestations of anxiety, like tremor and sweating and palpitations and all of that. So that's why we use beta blockers, basically. And so they're basically, when you're having I'll probably say basically too much, but when you have anxiety, you're basically releasing, did it again. So you release all of these catecholamines, this epinephrine and norepinephrine. That's what's causing all these physical manifestations. You're sweating, your heart's beating out of his chest, you're tremulous. By blocking those beta receptors, you help to deal with a lot of that, blocking the skeletal muscle, the heart, all of that. So you're going to be able to decrease all of these physical manifestations, right? So typically these are, again, as I mentioned, more in performance-based situations. I recall when I was in pharmacy school, we had a class, I don't know if I told you the story or not. We had a class called pharmacotherapy, where basically you ended up having a proctor at the front of the class who was facilitating a case. And so you had one meeting where you'd like actually go and have to interview the patient. So we get called on at random. So there's 50 of us in our class. You get called on at random to come up and ask questions, which was pretty nerve-wracking. But the problem is at the repeat meeting, you had to come up with a plan for the patient, write a SOAP note, and a team, and then they would call on you at random to defend your plan. So you'd say, well, I want to use this type of drug in the patient. They'd be like, well, why? What study says you should use that drug in the patient? It was incredibly nerve-wracking, and I was, because you never know when that sort of Damocles would fall on your head and you get called on to respond. You only had like 2 or 3 times in the semester to really get a good grade from that. And then when I heard some of my classmates were using beta blockers to help out their nervousness, I was like, oh, they're using performance-enhancing drugs. How dare they? And so I sort of, out of spite, said, I'm not going to do that. I'm better than that, which was ridiculous. But, so I probably should have just gotten a beta blocker prescription and been that much better for it. But after years of public speaking, I now am not so nervous anymore. But So someone's asking how long would the beta blocker last for anxiety? That really depends on the duration of action of the drug itself. So you'd probably be using this for like a very specific period of time. So say like over the course of maybe a couple of hours. So you could get away with a short acting drug, maybe, 2, 3, 4 hours. I would guess you'd probably have the maximal effects for the drug there, most likely. So anyway, so most commonly you think about things like propranolol or atenolol being used here. Obviously, if they have like a history of asthma, I'd go with the more beta selective one. Just depends. And you typically want them to try to do it about an hour before the performance. That way they have time for it to get into their system and have its effect before they have to go on stage or do whatever they need to do. However, keep in mind, you do want them to not take the first dose before the performance. Like maybe have them like a couple of days beforehand, try it out to see how they're going to tolerate it. Because if they get so bradycardic that they pass out, perhaps that's not good to find out the first time they take it when they need to get up and, I don't know, act as Hamlet or Romeo and Juliet or something like that. So that's one thing I would at least warn patients about is try it out first, see how it's going to go, and then do it an hour before the actual event. So for urgent symptoms, short-term benzos, usually 2 to 4 weeks or so, are going to be recommended here. And then at the same time, you can start SSRI or SNRI therapy. Either one of those are fine. And then if they're not urgently having symptoms, if they are coming in and they are saying, man, I just really feel anxious whenever, I'm thinking about school or thinking about relationships, whatever, you can just start them on an SSRI or SNRI. That's perfectly reasonable if they're not having acute issues right then. And then if they don't respond to it, try switching to a different agent. Maybe go from an SNRI to an SSRI. Who knows, right? And then if that's not adequate, then you can consider something like imipramine or TCA. Buspar could be considered here as well. So just see how they respond to it. But most patients should be good with one of those classes there. So I think I might have time to finish up this lecture set here. So let me continue on. But if you have questions, post them up. Real quick, let's talk about ADHD. So hopefully I still have your attention. Otherwise, may need some of these medications here. When dealing with patients with ADHD, obviously they have issues in terms of like concentration, being able to focus on one task before moving on to the next one. So, and again, we frequently think about treating kids with this stuff, but we also need to consider the adults that have now grown up with ADHD, or more adults are being recognized as having ADHD. So consider like what do you want them to do? Sit in their chair for 20 minutes, do their homework, be able to do their job appropriately, whatever the case may be. And that's going to be kind of your goal. That's going to be what you're going to be shooting for when utilizing these drugs to see how effective they are, right? However, you want to make sure that when dealing with these medications, it's good to have good coordination between the educational providers, make sure that the environment is consistent between home and school or work or wherever the case may be. That way, especially with kids, they're not getting, treated certain ways in school versus others. It may lead to some disparities there in terms of overall management for that ADHD. So something to consider with that. I'm going to have a question. Someone said, could beta blockers help with GI symptoms because of anxiety? Probably not. I'm trying to think. If you're having cramping, there could be like even that probably wouldn't be the case there. No, not really. It's mostly the musculoskeletal effects, the autonomic effects is what I would say with that. Maybe has a little bit of benefit, but I don't primarily think about like IBS. Remember we talked about IBS before. Beta blockers weren't really on that list there, and that's kind of a similar spectrum there. Anxiety going into irritable bowel syndrome, so probably not. Though, is what I would say. I could be proven wrong though. Anyway, so with treatment for ADHD, you're going to find that first-line therapy is going to be our stimulants, right? These are all going to be from the amphetamine class. And so we'll talk about the different amphetamine types, but basically they work by a couple of different mechanisms. They block monoamine oxidase. They, to some degree, they will inhibit reuptake of dopamine and norepinephrine. This is going to be these last two are the primary mechanisms here. Blocking reuptake of catecholamines and also increasing catecholamine release, right? So epinephrine, norepinephrine, serotonin, mostly norepi and serotonin to a little bit of degree there. So the problem with these drugs is that we're going to see that almost all of these, there'll be one exception here, they're all C2s, right? They're all have a risk for developing physical dependence and addiction to them. Some of that has to do with the fact that this increases dopamine release up in that mesolimbic pathway. So people like amphetamines because they feel good when they're taking them because of the dopamine effect. And that's why people that are addicted to things like methamphetamine and things like that. So Anyway, you're going to find that people may respond differently depending on the different amphetamine types out there. So if they don't respond well to dexmethylphenidate, you can try something like dextroamphetamine. You can switch around and see how they respond. Frequently, these come in extended release formulations, so that way a patient can take a dose in the morning and then not have to carry drugs with them or have that transported to the nurse, school nurse. They can just take one dose and they're good throughout the school day, for instance, and they can, be off of it for the afternoon, whatever the case may be. IR products, so you just have to take more frequently throughout the day. So here are the main ones you're going to run into. These are going to be methylphenidate, which you're going to find a ton of different brand names out there for the different varieties. So for instance, like methylphenidate, you have like the Daytrona patch that allows for kind of a long-acting release throughout the day. We have dexmethylphenidate. We have the combination of amphetamine and dextroamphetamines. That's called, they'll usually see like mixed amphetamine salts, how it's called. That's basically Adderall. You'll have lisdexamphetamine or Vyvanse. This one's actually pretty cool because it's a prodrug. It gets converted over into dextroamphetamine. The genesis for this was to be used as an abuse deterrent, because you would have people that would have these amphetamines, and especially if they have like a long-acting Adderall or something, you could crush that up and then snort it and actually get a pretty decent high off of that. And so that was something people would do to abuse the drug. Lisdexamphetamine or Vyvanse came out, and basically if you tried to crush that up and snort it, you would skip the first pass effect and not be able to convert it over to dextroamphetamine. So the idea was if they tried to abuse this, they really wouldn't get the effects out of it unless they took it orally and then allowed it to actually go through the liver. So again, ultimately how effective that is, I'm not really too confident about that, because if there's a will, there's a way. But that is where that came from. And I see a ton of kids on Vyvanse. They generally find it's still a pretty good drug. Again, all these are C2s, so they're all fairly limited in terms of being able to prescribe it, and it's pretty much under tight controls there. So in terms of adverse effects, you're going to see things like tachycardia, hypertension, potentially insomnia, irritability. All of that's related to the stimulant effects, kind of like having your sympathetic nervous system ramped up throughout a good part of the day there. And there's also some concerns, especially for kids with having reduced appetite, because a lot of your appetite suppressants are working through the same mechanism. So you can't see weight loss in a group of patients who probably need to be putting on weight because they're growing, right? There's also going to be some black box warnings for these, including things like hallucinations, psychotic episodes, and along with the risk for abuse and dependence. So that's why we want to be cautious with these, because we do know there are certainly some negative effects that can happen, especially from chronic use of these, for sure. As I mentioned, there's also high abuse potential, especially for patients with a history of drug dependence. So if they had a history of, say, like, even if it was like ethanol abuse or, opioid use or something like that, there's still some chance that they could be, become addicted to this as well. So I'd probably avoid using these if at all possible if they have that history there. In terms of withdrawal effects, this is not going to be the same as you would see with something that is sedating, like a benzo or ethanol. This is more so going to be, they're just really going to have, because like with the benzo, if you withdraw from that, you're really anxious and you're probably tachycardic and sweating, and, you're almost like having an anxiety attack. With the withdrawal effects from stimulants, it's usually like you're just really just run down and have no energy, and certainly not fatal, but they're not going to be feeling nearly as well as with the drugs on board. So you can't see that, but lesser clinical concern than something like a benzo. And then, as I mentioned, there are some concerns for growth stunting, probably to do with that reduced appetite and things like that in kids. So this is why you want to do things like drug-free trials, usually around like the summertime. If kids are not in school, that's a pretty good time to try utilizing that. Someone said, if Vyvanse stops people from getting high, why is it controlled? Because it'll still get you high if you take it orally. I mean, it'll still get converted over to dextroamphetamine through the liver. That was just a means of preventing someone from getting like an extended release dose all at the same time right into the nasal mucosa, where the bioavailability is really good, right? The intensity of the effect is going to be much more so by snorting a med, or insufflating, if you would like the fancy term, insufflation. The effect is much more intense than if you were just to take something orally, right? Just like if you have someone take, they smoke marijuana versus ingest marijuana, the effects are much more fast acting if you take it through the respiratory tract or some other mucous membrane versus the GI tract. So that's why it's still controlled. There still is a risk for abuse and chemical dependency. Yeah. Someone said, in regards to benzos, is it correct that lipophilic ones have faster onset of action versus hydrophilic, or is it the other way around? No, you were correct. Lipophilic drugs are going to penetrate the blood-brain barrier more readily. They're going to get in there, work more quickly. So onset of action may be a little bit faster for some of the more lipophilic meds than the hydrophilic ones. So like, for instance, like Versed versus lorazepam. I wouldn't ask you this on the test, but Versed, midazolam, has more lipophilicity. So it gets in and causes sedation or anxiolysis or whatever much more quickly than something like lorazepam, which takes a little bit longer to kick in. You're right. Have you heard of children getting Tourette's from stimulants? I've heard a little bit about that. I've not delved too deep into it. But yeah, I imagine if it could exacerbate some of their other psychiatric conditions, I could see maybe some of that happening there. But yeah, that's not something I'm super well versed in. I know someone who stopped himself from taking Ritalin cold turkey and started having nausea, vomiting. So is it possibly not due to the stimulant withdrawal? No, that's probably related to it. There can be some GI effects related to that. Not the same as you would see with like withdrawal from opioids, where your whole GI tract is waking up. But yeah, I could certainly expect some nausea, vomit. That would not be surprising if I saw that with somebody. But again, titrating off slowly is generally an easier way to do that for patients, because again, if you're withdrawing and have those symptoms, you're more likely to try to seek out and get that drug back. But anyway, so there are some other options. So for instance, like atomoxetine or Strattera. This is basically like an SNRI, basically. It is a selective norepinephrine reuptake inhibitors. This is more so used in adults for a while. I think nowadays you're seeing more adults getting treated with amphetamine-based products. And the onset of action is much slower. It's usually like 2 to 4 weeks versus just a couple of hours for the amphetamines. The benefit, though, is that there's no abuse potential with this. So this would be better for patients that have like a history of substance abuse in their past. This is a non-controlled substance, so it's nice from that standpoint. Keep in mind, though, that you're going to have that same risk for suicidal ideation, just like you saw with all the other antidepressants. That would be something I'd be cautious of. And then if they have hypertension, tachycardia, that can be worsened by this drug because of the extra norepi effects you're going to see there. So, someone said, I had a friend that opened the Vyvanse capsule and swallowed the powder and temporarily lost her vision and got very nauseous. Does that have to do with it being a prodrug or just a freak accident? That sounds more like a freak accident, because normally the capsules are not designed to impede like release of the drug. It's just holding the powder in there. I don't remember if Vyvanse comes as any sort of like pellets or anything, but yeah, it's interesting. I have to look more into that, but that sounds more like a freak accident than anything else. If anything, the prodrug effect kind of slows it down a little bit because that's to be converted first before it gets into the active form. But yeah, that sounds not like a very good idea. So I'm sorry for your friend. I hope she got better. I hope she can see the error of her ways, if you will. Also, I hope she can see. There's a couple other things we could use in addition. So like atomoxetine is kind of like a non-amphetamine stimulant. We have a few things that are more designed to kind of chill the patient out. And this is where we have our alpha-2 agonists. This is easy because we've seen guanfacine and clonidine before in use for hypertension. So again, these are depressing catecholamine release. So if you have someone who's really is too hyperexcitable, this can kind of chill them out a little bit. And I've actually seen this added on to patients who maybe get amphetamines during the daytime, but then they're way too anxious at night. And this could be used during the evening time to help kind of chill them out, get them ready for bed. It's not great to treat side effects with other medications, but you see it happen here and there. Obviously, it's not going to be as effective as the stimulants. And then sedation is going to be the biggest side effect you see with that, although you can develop some tolerance to that. Hypotension makes sense because we know how it works for hypertension, and some constipation can be seen as well. So treatment overall, generally you got to figure out, okay, well, what's the schedule? Like, when's the patient going to school? Looking to see what kind of adherence we need to think about. So that's why we like long-acting formulations for kids going to school, because they can take it at home and then travel to school and then be good for the rest of the day. Think about adults who may have comorbid conditions like hypertension. These are all things you want to consider when adding these drugs onto a patient's regimen. Basically, you're going to start with stimulants unless they have some contraindication, then going to something like atomoxetine or clonidine or guanfacine. And then you may need to consider too, if they need like help with in terms of like other concomitant conditions, like, if they have anxiety or depression that could be exacerbating it, treating that as well. So fairly straightforward. A lot of times it's just having kids come back, every month or so to see how they're doing with the drug and switching around either the dose or the agent itself to find what's going to work for them. And then once you get them on sort of a consistent drug schedule, then you can write them for a couple months at a time. Usually you'll have scripts you'll do, especially if they're like really steady. You'll do like 3 scripts for them at a time. One will just be for a month apiece, and they'll just say on the second one, do not fill until 1 month from now, and then the third one you say do not fill until 2 months from now. That's normally how you can deal with the controlled substance aspect of those drugs there. So anyways, I'm glad I finished with just a moment to spare. So that's the behavioral health section. So this is 410s. I think at 412, 14. I will probably only be able to get through OB-GYN for this next test. So I'm going to predict that the next test is going to be rheum, the orthopedics and pain management section, behavioral medicine, and then OB-GYN. And then endocrine will have to get pushed. So that's my prediction right now, but that may change in the next week. So we will see. Hopefully that gives you some guidance in terms of what to be studying for the exam. Any questions before I let all of you go? Otherwise, thank you for joining me. I really appreciate it. You guys are awesome. And thank you for being engaged. It really helps me feel like I'm talking to actual people, not just screaming into the void. And hopefully you get something out of it too. So yeah, have a great day. I'll see you all guys next week. Good weekend, actually.